Okay, emphysema. So hopefully you just watched the chronic bronchitis, and now you're going over the emphysema one. Emphysema is a little bit different. This is more of an irreversible the destruction of the respiratory zone that's irreversible in a lot of cases. Nothing really yet to reverse it, just sort of care to slow it down or to manage it. And so we're going to look at different strategies of how to manage emphysema and minimize the impact on someone's activities of daily living with it. A lot of times emphysema usually is a result of chronic destruction of the airways associated with chronic bronchitis. In other words, someone gets chronic bronchitis year after year after year, and then it's eventually going to cause that permanent destruction that's emphysema. So this is where the general path of smoking leads to, is those smokers will get chronic bronchitis year after year with all that thick sticky mucus, and it eventually destroys their airways, and now they have airways that are destroyed as well as a bunch of mucus that goes on. And emphysema, very, very sad condition. It's something that is mostly preventable. There's two types. There's genetic, where you could be born with it. It's an alpha-1 antitrypsin protease deficiency. I know that sounds like a lot, but that's where your body itself will destroy tissue as you get older. Remember we talked in pulmonary A&P about the respiratory zone having natural desquamatization, or destruction of the airways as you get older and older. Well, if that's normal, what happens here is there's a deficiency in something, that a protease deficiency that's supposed to stop or slow down the breakdown of alveolar tissue. So there's nothing slowing down the breakdown of tissue, therefore they have a faster progression of that destruction. So in this case, someone can develop emphysema, and this is genetic. Someone can develop emphysema by the time they're 14 or 20. So it can be pretty serious. So emphysema can be genetic, where someone may have never smoked a day in their life and they get it, or it could be from smoking. Now, there are types of people that are more genetically prone to emphysema. Your book will talk about the ZZ types and the MZ types, and alpha-1 in the genetic predisposition. There is some links to having a mild form of alpha-1 antitrypsin. So let's say someone smokes maybe a pack a day for, let's say, 3 years, and they develop emphysema. So it's sort of an exaggeration, I guess, but that would be someone that has more of a predisposition or doesn't have as much protease as a normal person might have. So some people are more predisposed to lung disease than others, just based on genetics. So that's something we'll look at. So remember chronic bronchitis, we talked about chronic bronchitis being a blue bloater is one of those things that you might hear people call them out there. Well, with emphysema, it's more of a pink puffer. Not as much cyanosis with this, but these people tend to be pursed lip breathers and that pink puffer type look to them. So we'll get into it here. So emphysema is a permanent enlargement of the air spaces distal to the terminal branches. So that's anywhere from this area on. So it's a permanent enlargement. In other words, it doesn't say it's a reversible enlargement. It's a permanent enlargement of these air spaces distal to the terminal bronchioles. So this is in the respiratory zone, and accompanied by the destruction of their walls without obvious fibrosis. So when we're looking at this, there's no fibrosis, there's no scarring of the tissue here. It's just tissue that's just destroyed, emaciated. It's just loose, floppy, destroyed tissue when you're looking at it this way. And then there's two general types of it. There's the alpha-1 antitrypsin, which is associated with panlobular, which is the one on the far right here. So this is panlobular over here. So we have panlobular on the right, and we have centralobular on your left here. And panlobular is more common in younger adults, like I said. Affects the lower lung field, so both of them affects the lower lung fields. These usually occur in non-smokers, and they have an alpha-1 antitrypsin. So alpha-1 antitrypsin protease deficiency is the full name of this. So alpha-1 antitrypsin helps prevent airspace destruction. So if they have a deficiency of this enzyme, then they're going to have an aggression of airspace destruction. So this is usually secreted by the liver, and it should be secreted by the liver, and it should help prevent the digestion of the proteins. So it inhibits the effects of enzymes that digest the proteins of the alveolar walls. So one of the first signs of alpha-1 antitrypsin protease deficiency, also known as alpha-1, is actually going to be high liver enzymes. So these are going to be usually the first lab that's abnormal on these patients usually isn't their pulmonary function test. Usually it's their liver enzymes, and that's something that you guys will see out there, is they'll have elevated liver enzymes. So ALT, AST, usually will be elevated with these alpha-1 antitrypsin protease deficiency patients. So that's panlobular. Centralobular is what you see here on the left, and this is more associated with chronic bronchitis. So this isn't, you get chronic bronchitis for that initial, right, initial dose, so the initial diagnosis. So let's say chronic bronchitis. Remember, you have to have 3 consecutive months in 2 consecutive years to be diagnosed with chronic bronchitis, or to meet the definition of chronic bronchitis. And now let's say that you do meet that. Now it doesn't mean you have emphysema automatically. This is just something that occurs over time with repeated bronchitis. So it's just eventual destruction when you're looking at this, but it's associated with chronic bronchitis, right? It's that destruction that happens. This usually destroys, and this is why it's called centralobular, the central portion of the respiratory zone. You're still going to have alveolar walls here, right? As you can see, looks like the old Minesweeper game if you're old enough to know what that is, right? But you're still going to have that central portion, that central area, this area here is what's destroyed, right? And it's more common in the apices. I'm going to highlight that, right? It's more common in the apices. So if you have emphysema from smoking, it's more common in the apices. Do you guys remember when I brought in those lung slides where I had a restrictive disease, obstructive disease, and a normal one? Right, and you see the emphysema one, the apice of the emphysema one is just Swiss cheese. It is just holes and hardly any tissue, and that's what you're looking at there. That is a centralobular emphysema that's most associated with chronic bronchitis, the central portion of the respiratory zone, and it's more common in the apices. Panlobular, more common in younger adults, more common in the lower lung fields. So this is the bases. So we're looking at bases, apices, right? So that's one of the things that we're looking at here. Non-smokers and alpha-1 antitrypsin deficiency is what's going on with panlobular. So centralobular and panlobular. You should know which ones affect the apices, which one is affecting the bases, which one's associated with genetics, which one's associated with smoking and chronic bronchitis. All right, so when we're looking at this picture, this is just a more detailed view of the centralobular versus panlobular emphysema. So when we see this, you're looking at panlobular emphysema, which is the alpha-1, right? You see the airways are just destroyed compared to the normal. And then in centralobular, the central part of the airways are what's destroyed. That's ultimately what you're looking at there. So when you're looking at the central part of the airways, That's C. Also, there's C is what starts with cigarettes, right? So centrilobular, cigarettes, the central part of the airways. Panlobular, I always think parents or genetics, right? That's how I remember it anyway. Parents, panlobular, that's genetics, and this is more destruction. So remember, centrilobular is more common in the apices, smoke rises. So it's more common in the apices, and panlobular is more common in the bases, right? And so you should look at sort of the genetic difference, genetic between centrilobular and panlobular. Centrilobular smoke, apices, panlobular is going to be genetics and bases. All right, so these are just healthy alveoli versus emphysema alveoli. And then this just depends which one we're looking at here. It's defined as the presence of a permanent enlargement, right? Repetition's the key to learning. Permanent enlargement of air spaces distal to the terminal bronchioles. This is the second time you've seen that. Accompanied by destruction of their walls without fibrosis, so no scar tissue showing up. So if there is fibrosis, then that's going to be some sort of restrictive process that's going on, and we'll talk about that when we get to restrictive diseases. So it's based on the anatomic alterations of the lungs with the disorder. So over here you see the healthy alveoli, lots of little circles, lots of little alveoli, and on the right you just see destroyed alveoli. And then also I want you to take note of this area up here. So in the healthy versus the normal, notice that in emphysema, not only do you have the destruction of the alveoli you see on the right there, but you also have a loss of destruction and loss of integrity of the airways that lead up to that respiratory zone. What does this mean? That means as negative pressure breathers, remember your lungs from pulmonary AMP, and then we have a chest wall. As negative pressure breathers, we generate negative pressure, and then that pulls the lungs out and open, which allows gas to flow in. When you're exhaling, so here, over here, when you're exhaling, you create positive alveolar pressure. So if the pressure inside the alveoli becomes positive, right, it becomes higher than what's in the atmosphere, that's going to what cause it to close. Well, as you have higher pressure in the alveoli, what's going to happen here is these airways that lead up to the respiratory zone are going to collapse when that pressure changes from negative to positive. When this relationship happens, these airways, these floppy little tubes that lead up to the respiratory zone, will collapse. That means that when they collapse, there's a bunch of pressure that's being built up and built up and built up in the respiratory zone. That's what causes that hypertrophy. That's what causes that alveolar overdistension, and ultimately even more destruction, is those floppy airways that go along with the destruction of the respiratory zone. So as a patient breathes, as they exhale, they're going to have a harder time getting air to flow out because the walls of the airway are collapsed in. So this is not because of inflammation like we see with chronic bronchitis. This is because they lost their integrity. So it's a whole separate reason why they're air trapping. It's not because of inflammation. Giving someone with emphysema anti-inflammatory, unless they have an inflammatory condition with it isn't going to work here to keep their airways open. You're going to have to give them something else to keep their airways open. And one of the easiest ways to do this is what we teach with pursed lip breathing, but we'll get into that a little bit there. CPAP is something else that you can do for these patients, some sort of positive pressure that should help stent their airways open so they can completely exhale as well. So we'll talk about more of this, but this is one key thing I want you to point out, or want you to see, is this whole floppy airway issue is going to be a key thing to remember with emphysema. It's not excessive mucus causing obstruction and air trapping. It's actually the floppy airways causing the air trapping. Right, so this is one of the pictures that you'll see in your book. With emphysema, there is not a lot of mucus. Notice that this is not a lot of mucus at all. So they showed over here letter A. This is from your book. This is just a normal alveoli in comparison to a panlobular emphysema. So panlobular, I see the P, I think parent, so that's genetic emphysema. So this would be alpha-1 antitrypsin protease deficiency. Whew. Right? And then C is going to be excessive bronchial secretions from bronchitis is a common alteration of the lungs. So this is if they still get their chronic bronchitis. Now, let's say their chronic bronchitis is under control. They're on inhaled corticosteroids. They've stopped their smoking. They're avoiding pollution and occupational exposure, right? They're doing well there. Well, now they're not going to have a lot of mucus, but they're still going to have that destruction of emphysema that they have to deal with. This is going to be central lobular emphysema. Central lobular, I think cigarettes, right? And remember cigarettes, smoke rises, so it's more common in the apices. So central lobular emphysema, you're going to have that weakening of the air spaces that lead up to the alveoli. And that's what's going to cause that destruction and that floppiness. This is what's going to create floppy airways and create that premature closure of the airways during exhalation, which will then trap gas in the alveoli, causing hyperinflation, which will then take these little capillaries, overdistend them, burst them, destroy them, and it creates even more of a VQ mismatch. All right, this is a lung slide. I think I took this one from your book as well. When we're looking at this, we're looking at just how much of the alveoli itself is left around. You see how the alveoli, hardly any of it's left over. This just looks like little squamous nothingness left over. It's Swiss cheese. It's not really tight and together like your normal lung slide. This is just excessive destruction from hyperinflation overall. Right? This is another one that I believe I took from your book as well. This slide is looking at the walls and the septa and the blood vessels around the air spaces. So A is what we're looking at here, a large, so this is the wall or the septa of an alveoli here. Try to outline it myself, right? That's what you're looking at here. That's that septa. So you can see how I drew that in there. That's that septa. And then B is normal lung tissue, right? From the lacing network and fragments here, and we're losing just this destruction that leads up. So this is the airways over here at letter B, airways that lead up to the alveoli septa. So you can see it's this destruction of B that leads to the floppy airways overall. All right, so alterations with emphysema. Guess what? There'll be summary slides asking you about what are common alterations with emphysema. Here is the slide you would look back to. Permanent enlargement. Hey, what's that? That's the third time I've said permanent enlargement of the destructions of the air spaces distal to the terminal bronchioles. That's the third time I've said where it is. Just saying, repetition is the key to learning. Destruction of the alveolar capillary membrane, that's because of the hyperinflation. So here is our alveoli, and then we have the capillary, that little blood vessel that surrounds it. Well, what happens when the alveoli becomes hyperinflated, right? So the alveoli gets bigger. Well, capillaries tend to have a little bit of flex, but what happens is they get pinched off, and if the alveoli gets too big after some time, it can actually cause the capillary to burst and then destroy that perfusion to that part of the alveoli. Now here's the thing, remember in pulmonary A&P, your respiratory zone, how does the alveoli, how does the respiratory zone get nutrition to the tissue, the type 1 pneumocytes? Like, how does it get its nutrition and replenish itself? Well, it gets that nutrition, that oxygen, that replenishing stuff from the alveoli, from the capillaries that are supplied to it. Well, if those capillaries burst, then does that alveolar tissue have the ability to get nutrition and replenish itself? It does not, right? Because there's now no more perfusion or no more giving it of any food or nutrition. So it will starve it. It will destroy. It will eat away at itself. So it's a pretty sad situation altogether. So the alveolar capillary membrane gets destroyed. This also means there's less surface area for oxygen to get into the bloodstream when you're looking at the bloodstream altogether. If we destroy all this tissue, we destroy a bunch of capillaries as well. What's going to happen with our ability to get oxygen from inside the alveoli to inside the capillaries if we destroy a bunch of those areas where we have both destruction of the respiratory zone and destruction of blood flow? You're going to have an issue with getting oxygen to the bloodstream, and that is one reason why they have to use supplemental oxygen in these patients, right? You're also going to have weakening areas distal to the primary respiratory bronchioles, all this weakening area that makes those airways really floppy, which makes them prone to air trapping, which makes them prone to this whole situation we just talked about, hyperinflation and destruction. So it is a bad cycle ultimately when we're looking at it. Okay, so let's do your imaginary thing. So put your imaginary respiratory therapy glasses on right now, right? Your imaginary stethoscope, put yourself in your own Pima scrubs, right? And now you're in the emergency room. You got a patient that comes in that's short of breath, and they're having a hard time breathing. The healthcare team asks you to go in and see what you think that the patient needs. And so what would this patient with emphysema look like if this were the case? So when you're looking at these patients with emphysema, one of the first signs, bedside signs, is going to be an increase in the anterior posterior diameter. So they're going to have what's called a barrel chest, that big AP diameter, and I have an x-ray in here that sort of shows that as well. Because they have chronic hyperinflation, that's not something that really resolves itself too much. It can resolve itself some, but not too much. Then we're going to see that these patients have a bigger AP diameter. So their ribs are going to have a bit further separation. You're going to see more of that larger thoracic cage type thing. It doesn't mean that their ribs have expanded. It just means the thoracic cage is still not quite there. So barrel chest. Remember, with chronic bronchitis, no barrel chest. With emphysema, yes, barrel chest. So emphysema, barrel chest. Enlarged barrel chest. Emphysema, enlarged barrel chest. Emphysema, increased AP diameter. Barrel chest. Okay, hopefully you got that. The other key thing here, what's DOE? And hopefully some of you already know what this is. This means dyspnea upon exertion, or so this means they get up to walk around, they get short of breath going from their couch to the kitchen, or the couch to the bathroom, or from the bathroom to the bedroom. So this is something that they're looking at where they have dyspnea upon exertion and or baseline, which is the next one, dyspnea. So this means that no matter what, every day, depending on how severe their emphysema is, and it's worse in the later stages, they can't catch their breath ever. It doesn't go away. They don't get a breathing treatment, and it reverses, and they can breathe better. They're going to have dyspnea all the time, 24/7. And unfortunately, especially when we get into sleep studies, patients with emphysema and significant COPD have very, very poor sleep, which means very poor mentation, which means activities of day, they don't feel good, they're grumpy, their mood's affected, right? They're going to have lots of issues there. So this is one of those severe things where they can't catch their breath. It's just baseline shortness of breath. Take a coffee stir and breathe through it, and then now breathe through that sort of the rest of your life. It's very, very sad, unfortunately. So baseline dyspnea, they get dyspneic on exertion pretty easily. They tend to hypoventilate, which means their CO2 levels are going to be increased. Yes, hypoventilation, which means high CO2 levels. Pursed lip breathing. Why do I bring up pursed lip breathing? And some of them will actually do it naturally without us coaching them to do it. So what happens when you pursed lip breathe? So right now I want you to take a deep breath in through your mouth and through your nose, and then exhale normally, just as you normally would. But now just do it with a big deep breath. Okay, so now I want you to do the same thing again. Big deep breath. I want you to go breathe in deeply through your nose, and then when you exhale, I want you to blow out like your lips are pursed together, like you're blowing out candles on a birthday cake, right? You're not forcing it out. You're just exhaling through that sort of pursed lip, that blowing out the candle's lip. So deep breath in through your nose, smell those roses, and then blow out. Right? You have that sort of through that pursed lip. You're going to see that it takes you a little bit longer to exhale when you do that. And you're going to notice that there's more back pressure. Because you created an obstruction, because you created a more narrow point of exit for exhaling, that means there was back pressure. That means that these floppy airways that led to the alveoli then got some positive pressure. So that means that now there's positive back pressure that's keeping the alveoli stented open. So this is a good thing. So this means that if they breathe out, they exhale normally here, their airways would collapse in, and then their alveoli would extend, and they would get hypertrophy, right? Over here on the right, you see that they got that positive pressure, which allowed for the alveoli and the airways that lead up to the alveoli to stay open, and which allowed for that exhalation to be complete. It allowed for the gas not to be trapped. And so pursed lip breathing is something that they can utilize at home when they're up walking from the kitchen to the bathroom to the bedroom, so on and so forth. When they're walking around, that's something they can use. They can pursed lip breathe, and that helps them sort of get that full exhalation and avoid hyperinflation there. So pursed lip breathing can be a very important thing. So positive pressure for these patients can be very beneficial to stent open the airways. Well, what happens with sleep apnea, obstructive sleep apnea? The tongue and the back of the throat collapse on itself when someone's trying to breathe in. So what's one of our treatments for that? Well, hey, we can put them on a CPAP machine, something that gives positive pressure to stent open the back of their throat, right, and their tongue. It stents all that stuff open so they can breathe fully. Well, we're looking at some of the similar things here. We're allowing that back pressure to stent open all those floppy airways that lead up to the respiratory zone so they can exhale more completely, right? These patients, so pursed lip breathing, if you walk into a patient's room and you see that pursed lip breathing, that can definitely be a sign that they are back pressuring. Even little babies will do this. If they need CPAP, they'll do what's called grunting. And we'll go over this in perinatology. Well, the expiratory grunting is their way of pursed lip breathing. Sort of that expiratory, that grunt sound, they're back pressuring their airway so they can give themselves CPAP. Pretty cool. Accessory muscle use, of course, very, very common on these patients. Did I talk about accessory muscle use with chronic bronchitis? Not really, unless they were in an exacerbation. So this is something that they'll do all day, all time, because they have baseline dyspnea, right? And so this is sad. Some people have their scalenes, their sternocleidomastoids, they'll have their accessory muscle use of choice. One thing that you might also see is where they have it, what's called tripoding, where they're sort of leaning on something to push up their shoulders to allow their rib cage to expand that much easier so they can still breathe a little bit easier. So accessory muscles, pursed lip breathing, dyspnea, baseline, barrel chest, these all should be signs of emphysema to you when you're looking at them. Breath sounds, when you listen to their lungs, usually they're going to be very distant and prolonged exhalation. So are you hearing wheezing and crackles? No, unless they have a pneumonia and or a asthmatic component, you do not hear that with just straight emphysema. Yes? Yes. So distant breath sounds that are just diminished, right? They don't have a lot of air movement because usually the air trapping is stopping them from moving a lot of air. So very diminished, very light, very hard to hear breath sounds. Usually they're prolonged. Heart sounds are distant because their chest wall is so hyperinflated. Remember, there's only so much room in the thoracic cage. If their lungs are hyperinflated, how much room is that for the heart? It is not, and that's why their hearts are tall and narrow, tall, thin, narrow on their x-rays. And so that's one of the things that you'll see there is their heart sounds will be softer, right? Distant heart sounds. If you were to do diagnostic percussion on them, tapping on their rib cage, you're going to note a hyperresonant, a drum-like sound. So very hollow drum-like sound when you're doing this. This is something that the board exams like to ask you about, and something you should just be aware of when we're looking at this. Alright, I'll let you guys look at Hoover sign in the text. Haha! Don't you love it when I do something like that? Sputum on these patients are usually going to be very scant, very mucoid, just not purulent like what we've seen with chronic bronchitis, but very scant, very small amounts, minimal, just sort of that white mucoid type condition. Unless someone with emphysema also has chronic bronchitis going on at the same time, then that's when you might see their mucus be different. But just in general, straight emphysema, I want you to understand just straight emphysema by itself, you're just going to have very scant, hardly any mucus goes along with that there. Fremness, what's fremness? Fremness is that sort of vibration that you would hear or feel, audible or tactile fremness. And so that's if you were to put your hand on the upper part of their sternum right below the collarbone and you have them breathe in and out, like you could feel that that vibration on their chest. That's that fremness, that tactile fremness. And so because this isn't very mucus related as far as just emphysema generally, you're not going to have that vibration. You're not going to have that really noted as much. What's the PMI? So that's the point of maximal intensity. So that's where the heart sound is the loudest. So it should be between the 4th and 5th intercostal space, mid-clavicular. There you go. And if it's not, then that could be a sign that there's something going on in the thoracic cage that's impacting the patient's cardiac or respiratory status, or cardiac respiratory status. So if their PMI is low, so what happened here, instead of being at the 5th intercostal space, it actually might be louder at the 6th intercostal space, right? Or their heart sounds might be very diminished. So if their PMI moves down, that's a sign of hyperinflation because the hyperinflation of the lungs are squeezing and pushing the cardiac muscle down towards the diaphragm. And so it's pretty significant hyperinflation there. And that's what it means by a low PMI there. Baseline evaluations. So if you have a person with just very mild emphysema baseline, their vital signs would be normal. So we're talking about you're at a doctor's office, you're shadowing a doctor, or you're an RT that works at a doctor's office, and someone comes in to the pulmonologist that you're working with, and just to see them, their baseline vital signs should be normal. The heart rate, respiratory rate, temperature, pulse ox, all that stuff should be within normal limits. Now you got someone that something happened and their emphysema is in exacerbation. So during an exacerbation, this is the one that I want you guys to look at, and I'll sort of give you that hint too on the test which one to look for, whether they're at baseline or they're during exacerbation. You should know if I give you a patient that has almost no mucus production, had smoked 80-pack year smoking history, had dyspnea upon exertion, dyspnea at baseline, their PMI is low, and then I tell you that the heart rate's 130, their blood pressure's 160 over 80, they are breathing 30 times a minute, and their pulse ox is 85%. On a lot of oxygen, then that's going to tell you this patient's in exacerbation. Their emphysema is significant. The tachycardia is, some of it is a little bit of anxiety. If you can't breathe, do you think you would feel anxious? Absolutely. Right, and so that's something that you would be looking at there. When you're looking at hypertension, this is going to be something we'll talk about in a second, but this is also associated a little bit with anxiety that goes along with I can't breathe situation. So that's part of that fight or flight sympathetic response that they'll have as well. When we're looking at tachypnea, this is because they can't breathe. And so if they can't breathe, if they can't exhale completely, then they're going to try to breathe faster. Because they can't get all that gas out and get all that CO2 out, their brain says, oh, you have more CO2 in you? Well, if I tell you to breathe faster, you're going to get rid of CO2, right? So their brain says breathe faster because your CO2 level is high, because your blood's acidic. It says breathe faster, right? This will correct it. And it's trying to correct itself, so it's going to tell the patient breathe faster, when in fact, if this patient does breathe faster, and they will, they're going to increase their CO2 retention. And so that's one of the hardest things to do, is tell someone that can't breathe, breathe slower, breathe less. Like, I can't breathe. Why? You cannot tell me to breathe less, so don't tell someone to breathe less. This is where you're sort of being that calming presence in the room. How are your kids, right? This is going to be something where getting them to do something like a pursed-lipped breathing maneuver where they smell the roses, blow out the candles, right, without getting hit. This is going to be something that's going to help them overall, because that slows them down, that stops them from trapping more gas, especially if they're using that pursed lip breathing. And then that's one of the things too, is if they can't catch their breath, if we put them on something that's positive pressure, like a CPAP machine or a BiPAP machine, or something that gives them that back pressure to help them stent open the airway so they can get that gas out, that's going to help resolve their tachypnea. And that's one of the ways I know I'm being therapeutic with a patient. If I have a patient comes in with emphysema and it's exacerbated, and let's say they're breathing at 35, 40 times a minute, and I put CPAP on them, right? I put them on a continuous positive airway pressure of 5 centimeters of water, and I see the respiratory rate drop down to 30, right? We're getting better. We're becoming therapeutic. They're not having to breathe as fast, because now I'm stenting open their airways. I'm allowing for more CO2 to get out. And that's ultimately saying to their brain, hey, we're fixing our acidosis. We should be able to slow down our rate of breathing now. And that's what happens. So that's one way you know you're being therapeutic, if their tachypnea starts to get better as far as their respiratory rate slows down, which is a good sign in this situation. Hypoxemia is another thing that you'll see with these patients. Like I said, their surface area is very restricted, or their surface area, should not use that word. Their surface area is very destroyed and diminished and low, and so that's going to have a harder time getting oxygen to their bloodstream. So when they get desaturate, they desaturate pretty significantly. On X-ray, translucency, so lots of darkness, right? Air on an X-ray is very, very dark, so it's going to be very radio lucent. And that's one of the things that you'll have to look at there, is it's going to be a lot of darkness because we have destruction of airway, so it's going to be very, very dark overall. Depressed or flattened diaphragms, we've seen that with chronic bronchitis. That's from that inflammation, that hyperlucency. overall. Their heart is going to be tall and narrow. This is something we already talked about in the X-ray lecture, which I know at least 2 of you hopefully have probably looked at. Tall, thin, narrow heart, because the thoracic cage is that increased AP diameter. It's squishing the heart, causing it to be smaller. Retrosternal airspace is going to be something very, very common with emphysema / COPD here. So that retrosternal airspace you're going to see on the lateral X-ray view and not usually the PA or AP view. So that lateral X-ray, usually you'll see that large retrosternal airspace, which usually indicates air trapping and the significance of it. Coro pulmonale and bulle, and I have pictures of bulle, can be noted with some of these patients. Like coro pulmonale, you'll see that right side of the heart's larger on X-ray, and sometimes you can see bulle, and I think I have some of those CTs and X-rays on here with that in it. Okay, so this is your classic emphysema. What do you notice about the heart? Very tall, very narrow on this heart. So let's go through the A through I technique. A is for apices. What do you notice about the apices? Well, here's our collarbone, right? When you're looking at the apices, they're very radio-opaque or very radiolucent. They're very lucent, right? Very dark. And remember, with emphysema, it's destruction of, if it's centralobular, it's more common in the, I heard you say apices, right? I believe that I heard you say apices. So you can see this destruction here. I'm trying to outline all these like bubble blebs, all these destroyed respiratory zones here that you can sort of see. They look like bubbles to me. Hopefully you can see them a little bit easier now that I outline. Maybe you can't, but you'll see that too. And eventually, as it gets worse and worse, the destruction will continue on down also into their lower lobes. So just eventually we'll just destroy tissue and destroy tissue and destroy tissue. Very radiolucent on these patients. Tall, thin, narrow heart. I would remember that. I would remember tall, thin, narrow heart for obstructive disease process. That column-shaped heart is just that squishing from the hyperinflation of the lungs ultimately. And that's also remember what can cause jugular venous distension and the feet and the ankles would swell up with edema as well. So that's something to look at there. Oh heavens, this looks like I drew a man with a mustache. Let's finish it. Little Groucho Marx glasses. That's good. All right, so when we're looking at this, a lot of destruction, tall, thin, narrow heart. So A is for apices, B is for bases. What do you notice about the CP angle? Is it nice and sharp or is it more flattened, right? It's, especially on this left side, this left lung over here, it's very, very flattened. We don't see a good sharp angle like we would in a normal x-ray. So flattened hemidiaphragm, ABC, C is cardiac, tall, narrow, D is diaphragm, and then we have like 11 ribs expanded here. A, B, C, D, E is esophagus, no G-tube. F is for fissures, don't see those here, so we don't have a lobar pneumonia or anything like that. G is gastric, I don't see any gastric restrictions or anything like that. H is hilar, yeah, there's a lot of hilar infiltrates here going on. HI is interstitium, not a lot of interstitium going on. We have a lot of destroyed tissue. It's more radiolucent than it normally should be. This is a lateral x-ray, so this is the patient faced this way. So this is the sternum over here, and then this is the spine back here, so you can sort of see. Patient doesn't have great posture, but there's the spine back there. So this would be the heart that you're looking at here. And so this patient's over here, and you can see this is the retrosternal airspace here. So let's use green. It's a good respiratory color. Green. So when we're looking at the retrosternal airspace, that's indicative of an increase in anterior posterior diameter, which is one of your clinical signs of emphysema. Costophrenic angles are very low, but you're going to see this is a very classic lateral emphysema x-ray. This is also a patient that's developed some cor pulmonale. You can see the right side of the heart, or if you're looking at like a shoe, like this would be the toe over here, and then this would be the heel on there. So the right ventricle would be the heel. The left ventricle would be like the toe of a boot or a shoe. The heel is going to get bigger and bigger, right? Grow bigger and bigger. A little bit of Grinch action there. So as that's one of the signs that you might see with him. So this person in A, which is the left one, and you can read it there. There's some issues with emphysema. We start to see the heart becoming tall and narrow overall. We start to see that hyperinflation, those flattened diaphragm CP angles. So we're starting to see this person on the left develop emphysema changes. And then the patient became chronically hypoxic, lots of respiratory infections. So that tells you their ability to fight off infections is lower. So what do you see with the interstitial? What do you see with the hilar area? You see a lot of those hilar infiltrates, which is a big sign of lymph tissue and things like that. That could be a big sign of infection, right? So that's what we're looking at here. I try to get you guys to answer even on YouTube. So this is what we're looking at here. And their heart and the vessels around the heart are enlarged. And this is something that's showing issues with this patient overall. And notice that you see the destruction in their apices. So is this centrilobular or panlobular? If it's more in the apices than it is in the bases. Now there is some destruction down here, but what do you notice? Right, so this is going to be more common in the apices, and this is going to be centrilobular. So it's going to talk about B, the patient is more associated with cor pulmonale and edema. And then they see the hilar markings is one of the classic signs of that. Well, you've seen hilar markings in both A and B. And so that's something that we have to look at. The emphysema and heart failure patients are very, very common where they can have both things going on. So we got to be aware, is this cardiac and respiratory? Is it cardiac causing the respiratory issues? Is it respiratory causing the cardiac issues? Because do you see hyperinflation on B nearly as much as you see on A? Absolutely not, right? We see flattened diaphragms on A. On B, you have good costophrenic angles over here, right? And if you don't know what I'm talking about there, please go and look at that chest x-ray evaluation presentation. Another classic one here, I think I took this one as well from your book, and this one's looking at emphysema as well. This one's pretty severe. What do you notice about the hemidiaphragms? Yeah, very, very flattened hemidiaphragms, destroyed tissue, tall, thin, narrow heart. This person does have some sort of left ventricular hypertrophy also going on, so probably a little bit of CHF at the same time. And then here you're going to see air bronchograms or destruction of respiratory tissue, and hopefully me highlighting them is helping you sort of see them a little bit better overall. So just destruction of tissue with blebs and bullae. Oh yeah, here's another one. I believe I took these from your book as well, and you can see the outlining of all this tissue that's just getting destroyed. Hopefully you can see that a little bit better if I'm outlining it for you. Right, so we're going to have these issues, and here is a CT scan on your right. And so this would be the spine here, this patient's laying supine, and then up here is the sternum. And then, so on a CT scan, it's a mirrored image, it's like Facebook Live. So if this is the sternum up here, and this is the spine down here, you would think that this is the right side, and then this is the left side. It is not. It's a mirrored image, so these are switched. So this is actually the left lung, and this is actually the right lung. Why it's that way, I have not looked that up. So there you go. So this is the left lung. Here you see the aortic arch. So we're somewhere near the mid to upper part of the lungs. Here's the trachea. And so here's sort of that airspace that you see in here, that retrosternal airspace going on here. And you can see some of these blebs and bullae and destruction that's gone on in here. You can even see areas of closed-in tissue and atelectasis. It's pretty bad stuff. Blebs and bullae, so similar to an aneurysm. So let's say my aorta, that tall, thin, not thin, but that tall, long artery that runs from my aortic arch all the way to my descending aorta. So I have a descending aorta, and then I have this area that sort of pooches out in the descending aorta. So this area here is weakened. So if I have that weakening, it's called an aortic aneurysm if it bursts. And so that's something where it's just this weakening and destruction of the airway wall or the arterial wall. And here, that's what you see here. You see how these are bubbles all over that lung tissue. And ultimately, it's just over-distended and destroyed blebs and bullae. These blebs are sort of encapsulated in, and if these pop, they can cause a small pneumothorax, usually not a tension pneumothorax, just a small pneumothorax. You'll see subcutaneous air and things like that with this as well. And they can go in and remove the blebs and the bullae. And I've seen some COPD patients that have exacerbations where they're hyperinflated, and they'll burst these and they'll have small pneumo with it as well. Here's another CT scan. Remember, the spine is down here, the sternum is up here, and remember, this is going to be the patient's left lung, and this will be the patient's right lung. Remember, they're mirrored images. And so you see on the right lung here how radiolucent it is. And I'm glad just to keep pointing these out to you. See how this destroyed respiratory zone. It's very sad. Right, and you can see this looks like just bowel loops on an x-ray. It's pretty significant. And so when we're looking at these, it's just those blebs and those bullae that are just destroyed and pushing in and restricting the ability to get oxygen into their bloodstream. All right, so emphysema on a PFT. So this is not a patient that comes in, shortness of breath, can barely have two-word dyspnea where they can get two words out. You're not going to be like, hey, let's go do a pulmonary function test on this person. No, that's not the right time. But if you're doing a stable pulmonary function test on a person that has emphysema, what would you see? So think about if it's an obstructive disease, what's going to be low with obstructive? Volumes or flow rates? Well, your flow rates are low with obstructive issues, so your flows are going to be low. So your FEV1 is going to be low or decreased, right? So your FEV1, how much you can exhale in that first second. Remember, they have a prolonged expiratory thing because they have destruction of those walls that lead up to the respiratory zone as well. So FEV1 is going to be decreased. Forced vital capacity. Forced vital capacity. So when we're looking at the forced vital capacity, this is usually low because they're trying to force. What happens when they force? The airway collapses, right? So this is a person that would be beneficial to also do a slow vital capacity. Remember, when you're thinking that a patient might have an obstruction issue, doing a slow vital capacity can help you rule out also a restrictive process. But a forced vital capacity usually is going to be decreased. FEV1 to FVC is usually going to be decreased. Peak expiratory flow rate, take a wild guess. It's a flow rate. Decreased. 25 to 75. This one usually is significantly decreased on these patients. Well, depending on the degree of obstruction, of course, but FEV1 to FVC and FEF 25 to 75 is going to be part of that as well. 200, 1200 also going to be low. MVV, which is your overall respiratory function. When you're looking at your MVV, this will be decreased. Now, here's one to look at. This is one of those ones that you should highlight on your little list when you're making the list that will be due and all that stuff. The DLCO, this is the only obstructive disease where the DLCO is low, right? So emphysema, cystic fibrosis, chronic bronchitis, cystic fibrosis, bronchiectasis, asthma, all those, their DLCO will either be normal or increased. And so when you're looking at this one, this is the only obstructive disease that tells you that the DLCO will be low. So this is the only one that will say this person has emphysema, is that DLCO. That's one of the things that sticks out. So if you were to do a pulmonary function test on a person that has mild asthma or moderate asthma, and you were doing a pulmonary function test on them, unless you had a DLCO, everything's going to look the same as asthma. All the stuff looks the same as asthma. So you're like, great, I can quantify how severe their obstruction is, but I don't know which obstructive process it is. Well, if we did a DLCO and it was low, then we know which obstructive process it is, because we know that the only one that has a low DLCO and is obstructive in process is emphysema. So that's something to pay attention to there. Volumes and capacities. Of course, you're going to have a lot of air trapping with this, so this is going to look very similar to your chronic bronchitis overall. So when we're looking at tidal volume, I know I'm going off here a little bit. So tidal volume will actually be increased, and this is because their air's trapping and they're using their inspiratory capacity. They're using their IRVs, so their IRV is actually decreasing. Trying to draw arrows here. Their IRV is actually decreasing, and we're using that because there's so much air being trapped in their lungs that they're actually breathing tidal volume higher up in their capacities and their volumes. So when we're looking at this, tidal volume is going to be higher. When we're looking at this, residual volume, so total lung capacity, we'll just go from bottom to top, is increased. Functional residual capacity is increased. Remember, this is all because of air trapping. Inspiratory capacity is decreased. Vital capacity, if we just did a slow vital capacity, if we did a forced vital, it would be decreased. If we did a slow vital capacity, it would be normal. Hopefully that makes sense. Right? When we're looking at residual volume, this is going to be increased. ERV would be, I think, yeah, ERV is definitely going to be decreased as well. So this is almost a mirror image, not mirror image. This is almost a direct copy of chronic bronchitis here. Okay, so what are we looking at here? Do they like their peripheral chemoreceptors like chronic bronchitis? Yes, they do. Mild to moderate stages, what's going to be their emphysema? So you have that patient, they have continuous dyspnea, now their dyspnea has gotten worse. They come into the emergency department, you're the RT that goes into their room. They want to quantify how severe their emphysema is, and they ask you for a blood gas. You do a blood gas, and then that can help you sort of tell what their severity level is, right? We're not going to stick them in a PFT booth if they can barely breathe. So how can we tell at the bedside? Well, one of the ways we can tell at the bedside how severe it is with an ABG. So when we're looking at this, they'll have initially an acute respiratory alkalosis. Remember, they get tachypnic initially because what happens? They get hypoxic, and their PO2 falls to 60, right? When their PO2 falls to 60, their brain says, hey, your oxygen level's low, and the brain, liking oxygen like a lot of other organs, says, hey, your oxygen levels are low, so I'm going to tell you to breathe faster so you can get more oxygen in your bloodstream. So that's going to tell you to breathe faster, and so they do breathe faster, and that sort of compensates. Right? It keeps their PaO2s hopefully at 60 or above. When this happens, initially, because of all the accessory muscles, their PaCO2 should go down and leave more room for oxygen. Great. Except for everything you're breathing with is skeletal muscle, which means eventually it'll tire out. And so when you're doing this, you got to look at how much CO2 is ultimately how long they can really compensate for. So in the acute stages, the mild to moderate stages of emphysema, they're going to have a respiratory alkalosis. Hopefully that makes sense. As the disease progresses, and this is no different, like I said, as they're compensating here, we talked about this, they're compensating, their PO2 is leveling, they're hyperventilating so they can get more oxygen to their brain and their kidneys and all those good tissues, right? And as they get into the late and severe stages, right, as they start to tire out, as their skeletal muscle says, you know what, we ran a marathon, I'm done. As their breathing tires, their CO2 levels are going to increase. Well, Dalton's law, as CO2 increases, is there going to be as much room for oxygen? Absolutely not. Their PO2s will decrease. So this is where you'll see that drop off. They'll go into respiratory fatigue and respiratory failure. So this is where you're going to see a compensated respiratory acidosis with mild to moderate hypoxemia. So hopefully their kidneys have kicked in. If not, you'll see that situation where they'll go into a respiratory acidosis overall because that CO2 level is now starting to climb. So the big thing here, just like we talked about with chronic bronchitis, look out for impending respiratory failure. If I draw blood gas on someone that's barely breathing, that's sweating, that's working hard to breathe, and let's say the respiratory rate's 40 times a minute, and I got a blood gas that's 7.40 and a CO2 of 45 and a PO2 of 60, and let's say the bicarb is 27. So if I got this blood gas, I'd be like, well, this is within normal limits, this is within normal limits. Hey, this is, if they're on oxygen, corrected. So this person's normal, right? No, they're in impending respiratory failure. They're heading towards respiratory failure. They're in respiratory fatigue right now, and they're going towards respiratory failure. So that's something you have to be aware of. A normal blood gas on someone that looks abnormal as far as their assessment goes for condition is not a good thing. So acute respiratory failure is when you would have that 7.20 CO2 of 60, PO2 of 55, and a bicarb of, let's just say, 20, right? They go into a combined acidosis because they didn't get enough oxygen to their tissues. So that's something that you would see there, is that respiratory complete failure overall. So pay attention to the blood gas. That's the way we can see at the bedside in an acute situation how severe their condition is. All right, oxygenation. What happens with them overall? So ventilation, perfusion, relationship. Do we have blood that's going to the lungs? Do we have blood, venous blood, that is making its way to the lungs? And the lungs are doing a great job at ventilating and exchanging the CO2. They are not, right? So what happens here is we got blood that goes to the lungs to exchange gas, and the lungs are not very good at exchanging gas. There's a lot of destroyed tissue, there's destroyed capillaries. So that means we got deoxygenated blood making its way to the oxygen or arterial sides. This is a shunt-like process. Even though we have dead space going on where we're losing perfusion, overall we're still shunting blood. We're not able to exchange enough gas with that blood. So this is a shunt-like process. The DO2 is going to be decreased. For this, that's the delivery of oxygen. Because we can't get oxygen, our CaO2 is going to be low. Our oxygen is going to be decreased. Content is going to be decreased. It's nothing to do with cardiac output. It's more to do with the actual ability to get the CaO2. Remember, their CCO2, their capillary content of oxygen in the alveoli, is going to be decreased, which means their CaO2 is also going to be decreased, right? If your CCO2 is decreased, your CO2 will automatically be decreased, right? Because you don't get it into your artery without going through the pulmonary capillaries first. So their CO2 is going to be low, therefore their DO2 is going to be low. Their delivery of oxygen is going to be low. Their VO2, which is their oxygen consumption, is going to be normal. Right? This is not a hypermetabolic condition or anything like that. Their oxygen extraction ratio is going to be increased. So this is where we were talking about before. If I have a bank account of $20 and every time I go to the bank I take out $5, right? This is my extraction ratio. I take out $5 every time I go to the bank, right? So now my CaO2 is low because my CCO2 is low. So no matter what, my tissues still demand that same amount. And now I have hardly anything to start with. So the ratio of what's left over, or the ratio of how much I'm taking, increases overall. So even though my metabolic demands are the same, my ratio of how much I'm taking to what's there is increased. So that means my ability, if I have emphysema, my ability to walk up and down the stairs at the school, my ability to walk around the block with my little dog, my ability to participate in activities of daily living are decreased because I don't have as much left over. I don't have as much oxygen left over for my tissues. So I can go into metabolic acidosis pretty easily. It can tire very easily overall. Your A to V gradient, your C A to V gradient is going to be normal. Like I said, this is not a metabolic issue. So don't get distracted by the O2 ER things on these. The O2 ER is low on almost all of these conditions because the DO2 is low. And this is that picture on this one you see of the guy pursed lip breathing, right? And here he's back pressuring into his lungs. That's where you see all the plus signs, and there's not a Duracell ad. You see all this, and he's back pressuring to stabilize the airway, so that way there's not as much closure, so that way they can get more of a complete exhalation overall. I thought I would put that in there for you. Much better than my drawings, of course. When you're looking at hemodynamics, when you're looking at central venous pressure, this is going to be high. This because the pulmonary capillaries are either destroyed or hypoxic vasoconstriction. They're going to have an issue where it's back pressuring, just like the pursed lip breathing, but in the hemodynamic world, it's all that capillaries are hyper inflated. The lung tissue is hyper inflated and it's squishing the capillaries and therefore back pressuring all the blood behind it. So my central venous pressure is going to be increased. Pulmonary artery is going to be increased, right? That's that back pressuring. Pulmonary vascular resistance is going to be increased because the alveoli are hyperinflated. They're squishing, right? Now they're squishing the capillary, and so it's making it so the capillary can't get any blood through there, and so all the blood back here backs up, and so this creates increased pulmonary vascular resistance, pulmonary artery pressure, central venous pressure. So these are all signs. If we put a Swan Ganz in these patients, this is what you would see. Now, just emphysema alone, their wedge pressure tells us how healthy the left pump is, how healthy the left ventricle is. If that's high, that's a sign the left ventricle isn't pumping very well. So is this an issue with the left pump? No, unless they have an underlying condition. So their pulmonary capillary wedge pressure should be normal. Their cardiac output will usually either be decreased or normal. So the reason why I say decreased or normal is because everything's back pressuring here. Right? So that's going to increase right-sided heart pressure, central venous pressure, all that stuff. But here's the thing. Remember we talked about our thoracic cage is only so big, right? Your lungs, right? If we hyperinflate the lungs, and remember there's things in here like the vena cava, superior inferior vena cava. If we hyperinflate the lungs, what happens to the superior and inferior vena cava? They get crushed, right? Not only does the heart get crushed, but the superior and inferior vena cava also get crushed, which means the amount of blood going to the heart initially is going to be very low. If we decrease the amount of blood going to the heart, what's going to happen to your cardiac output? It's going to decrease. That's why they go into that that's part of the reason why they go into that tachycardia, is they don't have enough stroke volume. So that's why they increase their heart rate, right? Because remember, what's the two constituents? What are the two factors of cardiac output? It's stroke volume times heart rate. Well, if we decrease the amount of volume going to the heart's going to be like, I got to make up for this somehow. I'm going to beat faster, right? And that's one of those signs. If I give a treatment to a patient with emphysema, let's say I put them on some CPAP to back pressure their lungs to help them breathe more efficiently, and I see them where now they're able to relieve some of this air trapping. So I'm actually fighting pressure with pressure, right? Now they're relieving this air trapping by me using my ventilator pressure or my BiPAP pressure or my CPAP pressure. By relieving that gas that's stuck in their lungs, by stopping that hyperinflation, I'm allowing for better venous return, which means if I'm being therapeutic, if I'm decreasing their air trapping, what would I see with their heart rate? Their heart rate would start to decrease. They would start to come back out of their tachycardia. They would start to breathe slower because they are able to get more oxygen into their bloodstream. So this is what I'm saying here. You have a patient in the ER in front of you. They're working hard to breathe. You put them on a machine, that positive pressure machine that helps them breathe, and you start to see their heart rate decrease, their blood pressure decrease, their respiratory rate decrease to more normal, stable signs. You are being therapeutic. You are helping that patient during that crisis. I hope that makes sense. Lab tests on these patients. Elevated H&H can be very common with these type of patients. Hemoglobin hematocrit, remember, this is more common in the late stages, and these patients can also have polycythemia as well from chronic hypoxia. Hypochloremia, we talked about this with the chronic bronchitis, and high sodium. These are more common in the late stages, and these are just some things that you'll see with chronic ventilatory failure. So I put those in there just so you'll see that their electrolytes will be off as well. Sodium and chloride, both of those, sodium is positive, chloride is negative, and so that's one of the things, that's why you will see a non-gap in one of these acidoses as well. Sputum, not really showing anything. Remember, chronic bronchitis, it could show a bunch of things. Therapeutic interventions, of course, if there's anything that's causing this, like smoking. Smoking cessation as early as you can. The best way to do this is smoking prevention. That's why I like doing the educator things for the third graders, like we talked about in chronic bronchitis. If the best way to quit smoking, never start. So smoking prevention. Occupational exposure, just like the chronic bronchitis, they need to avoid things that would irritate them, or like dust, fumes, all that good stuff. Indoor and outdoor air pollution, they need to stay away from those high pollution days if there's smoke in the air, things like that. And then they need to be physically active. They cannot just sit around. And so there's evidence behind this. There's two things that really help extend the quality of life for people with emphysema, and that's long-term oxygen therapy, LTOT is what it's called. So long-term oxygen therapy and smoking cessation. And physical activity is something that they'll get with pulmonary rehab that actually helps them become more efficient with the oxygen they use. It helps them feel better. It helps them breathe easier around town and around. So that's one of the reasons why I'm such a big advocate for keeping them active and pulmonary rehab. Therapeutic intervention, bronchodilators can still help some of these patients for sure. Why? Well, to remember, in the respiratory zone, there's no cartilage, right? So the transition airways in the respiratory zone, there's no cartilage. But what is surrounding the respiratory zone that does give it some structure? Did I hear smooth muscle? I hope I heard smooth muscle from some of you. Yes. So if I give someone bronchodilators, and even though they're not in bronchospasm, What do I have the potential of doing to their lumen if I bronchodilate those things that give them structure? Yes, that's right. I increase the size of the lumen, which makes it easier for gas to get in and out, which means I'm reducing air trapping. I'm letting gas come out because I'm giving a bronchodilator. So that's going to be one of the things that we'll look at there. Inhaled corticosteroids, especially if there's a chronic inflammatory process with this. Combination inhaled with long-acting. There's even triple therapy now, so that's something that we're going to be looking at as well. Studies continue to go on for long-term things. Oral corticosteroids can be helpful if they have a pneumonia that's going on. As well. PDIs, methylxanthines, these are sort of lower down on the list of things that they would do, but there's still options out there, right? Xanthines are your aminophylline, theophylline that would help increase your respiratory drive in PDIs. Other options, make sure that they're getting their flu shots, their pneumonia shots if they're over the age, I think 65 or something like that. Alpha-1 antitrypsin augmentation would be for those pan-lobular emphysema patients, and that's to help those patients. Interventions, so long-term interventions for emphysema, pulmonary rehab is going to be your big one. I'm a big advocate for it, for sure. No one's paying me to say that besides PEMA, I guess, which does not own a pulmonary rehab, so there you go. Treatment care specialists, in other words, help them understand their condition. This is going to be part of COPD education. And I love doing this with occupational therapy, physical therapy, nutrition, respiratory therapy, of course. And so we're going to try to get the patients to understand their disease better than they ever would have imagined. And our goal is to empower them, to get them to not be scared of their own process and to be active in knowing themselves and knowing what works for them and being a part of taking ownership of their process as well. Oxygen therapy is going to be one of your biggest ones. Ventilatory support as needed. Surgical treatments, this is to remove segments that are closed in, like bullae and blebs. We can remove lobectomies, things like that. They can put in the one-way valves to suck sort of areas closed that are permanently dilated, things like that will actually help these patients overall. Treatment of comorbid conditions, that's just going to help them as they get better health overall. That's going to help them breathe a lot easier, especially if, let's say, they had morbid obesity or things like that. That's going to help them overall. And then, of course, there's palliative care and life hospice. And they'll talk about, and I think Stacy talks about, putting someone on non-invasive. If they can't breathe, right, you don't want to go out not being able to breathe. And so it's one of the things that we'll actually do is put them on breathing machines to help them feel like they can actually breathe a little bit as they go. And so something we'll talk about more in the future. All right, review questions. These are for you to go through, and I recommend that you go through these in the PowerPoint and in the book, and I wrote this out of the book. 4 common lung alterations with emphysema. I hope you remember those. What might you find at the bedside? What would they look like? Would they be tachypnic? Would they be bradypnic? Would they be tachycardic? Would they be bradycardic? Would they have hypertension? Would they have hypotension? Would they have a dull percussion note? Would they have a hyper-resonant percussion note? What would they look like at the bedside? Right? Would they have dyspnea? Would they be fine? Right? What would their vital signs be? Right? What would be significant about their X-ray? Radiolucent, radiopaque. What's significant about the ABG? Would it be respiratory acidosis that they present with initially in the mild stages, or would it be a respiratory alkalosis? Right. What about severe stages? What about oxygenation? Is this a shunt or a dead space issue? What would happen to their right-sided heart pressures? What would happen to their left-sided heart pressures? What would their PFTs look like? Flows, volumes, anything abnormal about their sputum, right? Would you see things sort of growing and being in there? What type of sputum? Is it purulent or is it mucoid, right? What would the lab test show? Would they have polycythemia? What are some therapeutic interventions we use for people that have emphysema? Right? These are all things that will help you be that much better bedside practitioner, right? These will help you put together the patient condition a lot better. So I just want you to sort of put these things together. Like I said, put them on that flow chart that I was able to get for you. So yes, down here, know what impending respiratory versus acute respiratory failure looks like on the blood gas, right? If the patient looks abnormal and their ABG is normal in values, that's not normal. That's impending failure. If their ABG is acidotic and the patient looks terrible, that's obviously now respiratory failure.